Good afternoon and welcome everyone to the VPS Research Spotlight. I'm happy that you were able to join us this afternoon. We're going to go ahead and get started since this is only scheduled to last for 30 minutes and people are coming in pretty quickly now, but I think we'll go ahead and get started on today's talk. I'd like to introduce Mike McCrory. Mike is an associate professor at Winston-Salem Medical School in North Carolina. He's at Wake Forest University there. And he has been involved with the VPS for some time. He's been a member of our research group for a number of years and also is the VPS physician leader there at Wake Forest. Today, we're going to have Mike talk to us a bit about a recent publication that he was the lead author on, and he had a rather extensive list of co-investigators on this. So I think we'll hopefully have some time for questions at the end of it. But I think it's a very relatively important topic at this time. And we've had a number of inquiries to the VPS about looking at the social determinants of health. Mike and his co-investigators published this paper in Pediatric Critical Care Medicine late last year. And the title of it is Child Opportunity Index and Pediatric Intensive Care Outcomes, a multicenter retrospective study in the United States. So with that, I'm going to go ahead and have Mike go ahead and start to fill you in on what he actually did. Michael?
All right. Thanks, Tom, and thanks for having me. I'm going to share my screen here. Can everyone see that and hear me?
Yes, I can hear you.
Thank you. Well, I have no conflicts of interest to disclose. So a quick background, we know that social determinants of health have been associated with worse health outcomes in children and adults. And in children, lower SES or worse neighborhood environment has been associated with 7 years lower life expectancy just from where a child is born. Missed preventive care visits, increased use of EMS, urgent care, and ED services, as well as increased hospitalization. In the critical care setting, in adults, there was a systematic review and meta-analysis published in Critical Care Medicine by McCrory et al. In 2022 that showed an odds ratio of significantly increased odds. 1.13 was the odds ratio for 30-day mortality in critically ill adults from lower SES backgrounds. In critically ill children, the data are a little bit more limited. There are several single center studies using different indicators of poverty or neighborhood environment and showing that there's more use of PICUs, worse illness or outcomes, especially in respiratory diseases, particularly asthma and bronchiolitis. And there's some administrative data suggesting increased PICU readmissions. But for our study, we wanted to ask the question, does neighborhood environment affect severity of illness and outcome of pediatric critical illness? And we thought the VPS would be perfect data to use since unlike the other studies, or at least the other multicenter studies, it has the critical element of severity of illness, and in addition to high quality clinical data and diagnoses and so forth. So this was our publication up in the upper right. It's online ahead of print in PCCM, as Tom mentioned. And our data were from 15 children's hospitals that contribute to VPS. So we didn't actually get the data from VPS, and I'll explain in a minute because we had to add some things on, have folks pull their own VPS data and add. So when we started this a couple years ago, we wanted to get the most recent years of complete data. And so we got 2019 and 2020. And you can see our geographic distribution across the US here with a good geographic distribution with centers in the Northeast, South, Midwest, and Western parts of the US. And these colors represent the Child Opportunity Index, which I'm going to talk more about in a minute, with white indicating areas of lower opportunity and dark of higher. So a quick aside to talk about area level indices of social determinants of health. So we use the Child Opportunity Index 2.0 version, which was updated in 2020. And it has 29 indicators in these 3 domains: education, health and environment, and social and economic. It's considered the most pediatric specific indicator of social determinants of health or neighborhood exposure, and I'll show why in a second. It was established almost 10 years ago to fill an urgent need for equity-focused research to improve child well-being and increase equity. And so the data are used for all kinds of different projects, not just in health, but in educational and policy type projects. And it's housed at Brandeis University. If you go to diversitydatakids.org, again, I have no conflicts of interest. They're a nonprofit, but they have a great website and are very helpful. And you can type in any address and get the COI indices on this site, or you can register and download the data so that you can map census tracts or zip codes. So these are all the individual elements of the COI in the 3 categories. And I just want to call attention to the educational opportunity category, because this is where it's much more pediatric specific. There's mention of early education centers, early education participation rate, high school graduation rate, some things that just aren't in other indicators. And then the social and economic and health and environmental opportunity areas are also very important and include things like proximity to parks and open spaces, which could certainly influence kids' health as well. Quickly, just to mention some other area level indicators that we considered but didn't use for this study that are often used and have been used in other studies. The Social Vulnerability Index, which is housed and maintained by CDC and the Agency for Toxic Substances and Disease Registry. It has 16 components. It's at the census tract level, which is the same as what we used with COI. It's an 11-digit indicator of address. And there are about 4,000 of them in the US. I'm sorry, there are about 4,000 patients per census tract, and there are over 70,000 of them in the US. But you can see it has similar indices, but not quite as pediatric specific. And then the Area Deprivation Index on the right has been around for more than 20 years. Originally created by the Health Resources and Services Administration through the government, now housed through University of Wisconsin, their health equity research department there, and they keep it updated, and you can get those data through them. But they actually have that mapped to block group, which is even more specific than census tract, and that's a 12-digit number, so it's slightly more specific indicator of neighborhood than tract. So anyway, getting back to our study. So what we did is ask each of the 15 centers to pull their local VPS data of all their PICU admissions over those 2 years, excluding cardiac surgical admissions, because we felt we couldn't control for severity of illness as well in those. Then and we leveraged the POLICE, or the Pediatric Acute Lung Injury and Sepsis Investigators Social Determinants of Health subgroup, to help recruit folks who were at centers that were also VPS participators and would be interested in this project, and the PIs would be able to collaborate. Then once they had the admissions, everyone obtained the addresses, the primary payer, and the primary language from the local electronic medical record. Then they fed those addresses through the U.S. Census Bureau. They have an online tool that allows you to get census tract from a batch of addresses. Once each site had those addresses, they could map them to the Child Opportunity Index through the mapping file data set from Diversity Data Kids. And we use the nationally normed rather. There's also metro normed values. And those come as both so it's a 1 to 100 ordinal scale, and then it's broken into quintiles with the whole U.S. population equally divided, 20% in very low, low, moderate, high, and very high quintiles. And then the sites send us the de-identified data, so no addresses, just the COI indices. We aggregated the data and analyzed it with the hypothesis that lower Child Opportunity Index would be associated with higher severity of illness and higher mortality in PICU, but similar severity adjusted mortality. So this was our study flow. Just quickly to mention that we started with 50,000 admissions from the 15 centers. We excluded the readmissions and the patients over 18. Then we had to exclude some patients who didn't have an address that we could really map, but this only ended up being about 600 patients. So a little over 1% of the data. So most of the patients had street addresses. And then the real hangup was getting through the census geocoder. Sometimes there were glitches with trying to map addresses to GeoIDs. And we tried many strategies for that, and we're able to end up getting most of them. And then the Diversity Data Kids COI files were excellent, and we were able to map almost all of the GeoIDs to COI. So that gave us 33,901 index admissions with COI in the primary analysis, and it was median of 2,000 per center. We had over 19,000 unique census tracts represented. And these were the demographics. Just to quickly mention, we had a good grouping of different ages. This was our race and ethnicity breakdown as indicated in the VPS data. And then here was some of the EMR data that was additionally obtained. The government insurance was the largest category of 57%, and that's Medicaid, Medicare. Commercial insurance was second. Some patients had no or missing insurance data or were self-pay. And a lot of these other were TRICARE, which is military insurance. And originally we were going to include that in government, but there are some data that those patients are systematically different from other types of government insurance. So we made them an other category. Here's the primary language spoken breakdown and the origin of admission and year of admission. Of course, we had fewer admissions in 2020. So the overall clinical features, before I get into the main findings of the study, our mortality was 2.14% with a length of stay median of 1.4 days. Invasive mechanical ventilation occurred in 23% of the patients, and the PIM3 risk of mortality mean was 2.44 and median was 0.71. So this is our breakdown of the COI quintiles of the PICU patients. So you can see that the largest proportion was very low, 27%. And remember, it's standardized to 20% per category in the overall U.S. population. And as you got to the higher COI categories, the proportion of the PICU patients decreased. Now, we don't know what the neighborhoods that these hospitals serve, if this is representative of the overall patients that they serve or not. But I think it's interesting that if you look at two other big studies of EMS and ED use, there have been hypotheses that kids from more deprived or lower opportunity neighborhoods may use emergency services more because of problems with transportation or problems with having primary or care or other offices that they can more easily go to. But our data so far would suggest that the proportion from the very low is actually very similar to the proportion of very low and very high, was also similar in the EMS, in the continuum of EMS pre-hospital, EDs, and then in PICU patients as well. So it was kind of an interesting parallel there. Just to check some of our categories and see if there were differences between very low and very high, that's similar to previous studies or kind of what we'd expect. Government insurance was higher in the very low group. Primary language of English was lower, and unscheduled admissions were higher in the very low COI group as compared with the very high. These were some of our main findings as far as clinical characteristics. We were interested in whether kids from very low COI groups would be sicker on admission. And what we found here, if you look at the PIM3 risk of mortality, the median is a little tough to tell, but if you look at the mean, you can see that the moderate group actually had the highest risk of mortality, so they were the sickest. But consistently, we found that the high and to some extent, the very high and to some extent the high groups were the least sick and had the least mortality and generally a quote unquote protective effect of being in those higher groups. So that was sort of interesting. We did find a higher proportion with respiratory illness in the very low versus the other groups. And the mortality again was highest in the moderate, lowest in the very high and high groups. This was our length of stay graph. It was statistically significant, but the median was within 3 hours for all categories. So it didn't appear to be particularly clinically significant, but it mostly mirrored the severity of illness, with the moderate being the highest and very high being the lowest length of stay. As far as ICU interventions, we found that invasive mechanical ventilation, just like severity of illness, was lowest in the very high group and highest in the moderate, but limitations on care were similar. With no statistically significant difference across groups. And our reviewers asked us to do pairwise comparisons so we could tell whether each group, very low versus very high, et cetera, were significant. And I just want to point out that consistently the very high group was the different one. So very low was different from high and very high for risk of mortality. Low was different from high and very high. Moderate was different from high and very high. In mortality, moderate was different from very high. And then in mechanical ventilation, also low, moderate, and high were different from very high. So it seemed more so than very low being much different. It seemed as if the high, very high, and maybe the high groups were kind of consistently having better outcomes than the other groups combined. So getting to our multiple variable analysis. So we did a logistic regression with multivariable mixed effects, so accounting for different centers with the outcome of PICU mortality. And we did adjust for PIM3 severity of illness as well as age, sex. And to get into our variables of interest, race and ethnicity, the only significant finding here was that unspecified, which was a fairly low number, was associated with higher mortality, but none of the other groups were significantly associated with the difference in mortality. For payer, government insurance was equivalent to commercial. The interesting thing here is that none or missing was our highest odds ratio for mortality. So 3.5 times odds of mortality in patients with none or missing insurance. And this was over 1,600 patients. So it was, only a couple percent of the data, but still quite a few patients. And I'm going to get back to some characteristics of this population in just a second. And then for primary language spoken, we didn't find any association there. And now getting into our main variable of interest, looking at child opportunity index quintiles. So our very low quintile did have the highest observed odds of PICU mortality at 1.3, so 30% increased odds, but the p-value was 0.11, so it did not reach statistical significance at our p of less than 0.05. Interestingly, when we plugged COI on the ordinal 1 to 100 scale into the multivariable model instead of using the categories, we did find that the odds ratio was less than 1, meaning that as COI increased, the risk of PICU mortality decreased, although that was just at a p of 0.05, so it didn't quite get to our statistical significance limit of less than 0.05, but still very interesting. And now just getting into a couple of secondary and sensitivity analyses, and then I'll wrap up. So we also looked at the subcategories of COI, the education, health and environment, and social and economic subcategories. Interestingly, we thought the health and environment might be the most important, but actually that was the one that showed the least difference between any of the groups and the very high in terms of odds of PICU mortality. High was lower than very high, but it's hard to really understand why that would be. But in the education and social and economic groups, the odds ratio in the very low and low groups were a lot more similar to the overall. So that was sort of interesting, but none reached statistical significance here in the subcategories. So we did some additional analyses informed by the data in some cases. So because that none and missing insurance group seemed interesting on the multivariable analysis, we looked into the demographics there. And it was actually fairly similar, a little bit higher percentage white, 57 instead of 46%. The percentage of Black race ethnicity was the same. Hispanic was lower. And the rest was similar, and also similar in English speaking. So kind of interesting there. We also plugged in interaction terms with COI into the multivariable model to see if groups from certain COI quintiles might be more vulnerable if they didn't have insurance, but we didn't find any significant interactions there. And then for sensitivity analysis, we plugged in a few differences into our model. For severity of illness, we used PRISM-3 and got essentially the same odds ratio. We used the time frame of the COVID era, just since the PICU admissions were systematically different, and got again, the very low COI odds ratio was again around 1.3. So again, not very different, not statistically significant. And then since we had only used 90% of the data with our census tract matching, we tried again with zip code matching, which isn't considered as specific for neighborhood. There are roughly half as many zip codes as census tracts, but they're kind of separate. But anyway, we were able to get over 97% of the data with zip code, and we got a very similar odds ratio again of about 1.3 with similar P of 0.08. And then finally, we combined the high and very high group. Since the high had an odds ratio of 1.0, it seemed similar to the very high group. So we compared those high and very high group against the very low, low, and moderate in a multivariable model, and got an odds ratio of 1.19, which was again P of 0.10, so not statistically significant, but interestingly, it is quite similar to the odds ratio found in that adult critical care, that population of adult critical ill patients. That meta-analysis found an odds ratio of 1.13 for 30-day mortality, so that seemed interesting. So just to wrap up, some of our strengths, we were fortunate to be able to use VPS data, which is high quality clinical multicenter data with adjustment for severity of illness. Some of our limitations, we had a group of all urban academic PICUs, so it may not represent the overall population across the United States. There's always question about whether what's recorded is accurate in terms of race and ethnicity, and it definitely was a bit different from the U.S. overall population, a little bit lower percentage white and Hispanic, and a little bit higher percentage identified as Black. And then we use area level, not individual SES indicators. In other words, we were assigning neighborhood, but we don't really know if that family actually has, some of the challenges or any particular problems based on that. And then about half of our addresses were at the time of data pull, which was up to 2 years after the admission. So we don't know if they were actually still in the same neighborhood, although it wasn't too much longer. And in many cases, it was less than a year. So just to wrap up, children admitted to the PICU at 15 academic centers in our study were most often from the very low COI category. Children from the high and very high COI category had the lowest severity of illness and PICU mortality. In a multivariable model, children from the very low category had the highest observed odds ratio. It was not statistically significant at p less than 0.05, but we couldn't exclude our 95% confidence interval went up to almost 1.8 times higher mortality. So, and then the COI as a continuous variable was right at p of 0.05 and was less than 1, suggesting that as COI increases, PICU mortality goes down, even severity adjusted. And so in the future, we're going to be evaluating the subgroups that we suspect may be the most sensitive to environmental and neighborhood factors, such as asthma, trauma, chronic complex conditions, DKA, and we have different groups in our author group working on these things. And then, in the future, certainly we want to continue to make sure we're screening our patients so that we can support them and also get more accurate and individualized data to evaluate what they need and how that may correlate with health outcomes. So thank you so much to VPS, to my colleagues, the Polisi SDOH subgroup, especially Dr. Zakande and Slane, who really helped me get this going. The diversity data kids staff that run the COI are extremely helpful. My collaborators at Wake, and then my collaborators at the other participating centers. We couldn't have done it without all these people. So thank you. And I have these references. If anybody wants to request them, I'm glad to share them.
Yeah. Thank you, Michael. I would like to remind everybody on the chat box or the Q&A box, please enter questions. We have 7 or 8 minutes that we have opportunity to ask Mike some questions that he may not have targeted for us. I mean, I'm going to ask you one, Mike. How did you enlist your group of co-investigators? Was that primarily through the Polisi setup?
It was some of each. And well, first I touched base with Nancy, so she knew about the study, but we realized that we were going to have to sort of collate other data at this time because getting address and census tract wasn't something that's in, or COI or anything wasn't in VPS yet. So I reached out to some colleagues who I'd worked with before on VPS studies, like Martin Wakeham. We had worked on a trach project together. And then it was announced at the Polisi SDOH meeting, and we got interest from more folks. And it actually, that became one of the bigger challenges of the study. Everybody has different levels of experience or statistical programs that they like to use and whatever, and trying to get everything in the same format and amalgamated took longer than expected. But we have some really interesting data to look at.
Great. There's a question here. Can you speak to whether there were differences among the centers as to transport distances? Do we know anything rural versus urban?
Yeah. Oh, shoot. Sorry, I just closed my screen. We don't know. That's not something that we collected from the VPS data in terms of we have origin of admission, but that's certainly a question that's come up that we may need to look at in future studies, like distance from critical care. Mm-hmm. I think it would be tough because something like a third of the patients or so were transferred from outside hospitals. So even if we could map the distance from their hospital to the index ICU, I guess we could just look at transport mechanism though, and that's an interesting question. But no, as of now, I don't have that information. So that's a good question.
Another comment. There's one here from Barry. It says, "Great work, Mike. Love this. Question for Tom." Oh, it's for me. Is VPS considering starting to collect COI at the time of admission? I can answer that, Barry, and we're setting up a task force within VPS to look at the social determinants of health, and certainly adding COI to that has come up through Matt and actually through Mike's paper. We had some discussion at the Pediatric Advisory Group last fall, so there's a lot of interest in it, and we're going to try to have some discussion and get some recommendations before we start tackling and trying to enter some of this information. But no, we're very interested in it. Another question here from Gerardo. He's asking about the quintiles distribution of COI. Did you stratify the COI categories by race, ethnicity? And if so, what did you find?
Well, COI categories are certainly known and have been reported in other studies to be imbalanced by race. We included both of them in the model a priori, and we didn't find collinearity, so we left them both in. But we didn't report the stratified results. But they certainly, race is not a part of COI, but it is part of SVI, I think. But we thought it was important to include both in the model, and it's definitely imbalanced across COI categories. It's been reported in other studies.
Thanks, Mike. There's another question here that you might be able to answer regarding the addresses at data pull time versus admission. Was there a range in the general time gap between the two?
Well, we didn't ask folks to give us an exact time gap. We just asked them to say when to try to pull it from the time of admission if possible. And if they couldn't, just pull it from the time of data pull and then tell us which one they did. People were pulling the data mostly in like early 2022 or early to mid 2022 when we first started this. So, you know, from admissions from starting January 1st, 2019 through the end of 2020, that would be kind of the gap. It could have been as much as 3 years. So, you know, we were hoping that people could get at the time of admission, but it was just based on what people were able to get at their center through the EMR.
Sure. I have a question. Do you think that the COVID pandemic affected the findings at all? Since you covered, you know, 19 and 20, we would have had the first big year of COVID in there. It's clearly, it affected the number of patient numbers that you demonstrated there, showing that it was down the second year. But just concerned whether or not that might have affected some of the other findings.
Yeah, absolutely. I mean, we know that the admissions during that time were systematically different, not only lower, but you know, there have been papers published that there were some different characteristics then. That's part of why we did that secondary analysis of just the March to December period. We did find an even higher odds ratio for the very low at like 1.34 or something. We have not, although it wasn't statistically significant, of course, the numbers were lower. You know, we had thought about looking at COVID and MISC, but it's just changed so much. It's hard to know how relevant it would be now. And I think we definitely do need to look at this with more recent data as all of this has evolved with the pandemic.
Well, it's very thought-provoking, and I think it certainly is going to have some impact on us going forward. From the VPS end of things, I think I already kind of indicated what I think some of the impact on VPS is going to be, because we're starting to consider what other information we could potentially either link to, integrate, or pull into the VPS registry. So we're right at the 2:30 mark. I don't see any other further questions at the moment, but we will provide follow-up for you, Mike, with participants and that kind of stuff. Again, I appreciate your participation today. Very interesting paper, and look forward to working with you in the future.
Great, thanks a lot.
I'd like to thank everybody else for joining. Please keep your eye out for our next one, which will be in about 3 months. And unfortunately, I can't remember the exact date, but it'll be on a Wednesday. I know that. All right. Thanks, everyone. Appreciate your participation.